The pressure pulls it back out of the patient and into the drainage bag. So, if you look at this, I tell the people I'm teaching how to do PD that this setup looks kind of like a foot. Big toe, toes. It's got 6 toes, but my brother-in-law had 6 toes when he was born, so it happens. But the 6th toe down here is connected to the drainage bag, and this little clamp here, vitally important. This big clamp, also vitally important. Little clamp, open. Big clamp, closed. Little clamp, things move the right way. Big clamp open, big mess. Because I kind of forgot to close a clamp one time and got a phone call in the middle of the night. And so that's why the nurse that set this up for us was kind enough to throw an extra clamp on here. So this machine also warms the dialysate, and there's a little silver disc right here in the cradle that heats the solution up to body temperature. And you may see these. I'm sorry, you may.
No. Then I'll be able to see you.
Oh, this computer.
Yeah. Or maybe.
Is that better? So you may see these with multiple bags set up on them, laying multiple ways. The bag with the red clamp is the first bag of the setup. This is the first bag that is instilled into the patient. If there's multiple bags, it's going to pull fluid from this first bag, instill it into the patient. And then that pressure system I mentioned earlier is going to pull fluid from one of the secondary bags and push it into the first, because the first bag is always on the heater cord. Thank you. And so that way the new solution will be warming up. Hi, welcome aboard. I'm Diana. We're glad you're here. I'm going to grab the remote. Good morning. So these machines are pretty smart. We made them, for lack of a better term, idiot-proof. Because you never know which patients are going to, or the caregivers are going to take care of them, what their education level is, things along those lines. So we want to make it as simple as possible. Hence, stop and go. It doesn't get much more basic than that. So we're going to do a little hands-on with this once I get through the presentation. So I just wanted to give you a quick rundown on what this actually is. And our presentation today has the objectives of, let's see, up, maybe, down.
You want me to push the buttons over there?
Yes, please. If you hit the down button for me.
321, new patient arriving, 321.
Yeah, I can click buttons if you want a video.
Okay.
Thanks, I've got it. Look at that. I've got my own roadies that set everything up and run it for me. I feel like pink or something. Our objectives today, what PD is and what it is not. How to troubleshoot some common PD problems, which is the meat and potatoes of why you're here. And how to transport patients after treatment is started. Next slide, please. What PD is. Peritoneal dialysis. As I mentioned, this is a home modality. Patients, caregivers do this in the home. They do it on a daily basis. So they are doing this every single day. And as I mentioned, they go through in-depth training on how to handle their catheter, how to hook everything up, and they are very, very conscientious about it. So, PD, it's really hard to kill somebody with peritoneal dialysis. unless you give them peritonitis. If you remember nothing else today, remember that peritonitis will kill somebody, just not fast. We can kill them on hemo just like that. This one is a long agonizing thing. So we want to avoid all of those. That's why we're all here today. This is patient and family directed. In some hospitals, the physicians write orders that the patients can hook themselves up and take themselves off. Other hospitals that don't offer peritoneal dialysis will have the family bring in the machine, the bags, everything. And the patients will do their own dialysis in the hospital setting. And then the nursing staff has nothing to do with it because that's not a service that the hospital provides, but the patient still needs it. They also do it on their schedule. So if they're doing it with the machines or they're doing manuals, they do it according to their schedule. If they travel, they will notify their provider of supplies that they're going to Disney World, and they'll drop ship supplies to them, so all they have to do is take their cycler. If they're going on a cruise, same thing. They can take all of this with them. They can travel. It gives them a lot more freedom. And it's a lot less restrictive. So like I said, they don't have a chair time. They don't have to be up at 4 o'clock in the morning to be in a chair by 5. They do it at home. They either do manuals where they instill the fluid, walk around for a few hours, and then drain the fluid, or they do the cycler, and they can hook it up and go to sleep, and the machine does all the work. If I ever have to be a dialysis patient, you're looking at my future right here, because I don't have time to be sitting in a chair 12 hours a week. Also, their dietary restrictions are different. Your hemo patients, they usually have a fluid restriction. They usually have potassium restrictions, high protein, all those things that you see on the renal diet. These folks tend to run a lower potassium because they're getting treatment daily. They have fewer fluid restrictions because they're getting treatment daily. They are more active because they're getting treatment daily. But as a result, you're going to see elevated BUN and creatinine levels because they are much more mobile, moving, healthy. But those levels are going to be higher than what you would see in a traditional hemo patient. But that's okay, we expect that. So if you have a PD patient and you get a call from the lab on a critical creatinine, don't sweat it because we're not going to either. That's supposed to be there. PD is not emergent. This is not a quick fix, usually. If you have a patient who's not done their PD in 2 or 3 weeks, and they're all balled up, can't breathe, we're not going to be able to save them with one peritoneal dialysis treatment. They'll probably need an emergency hemo treatment. We can fix a lot of stuff with PD over a gradual time frame. You may also, now that they're going to start placing peritoneal dialysis catheters here, want to be able to monitor for some of those problems. So when those are put in, they're usually addressing over the top. Don't touch it, don't breathe on it, don't look at it. Just talk to the surgeon, because we usually leave that under wraps until it's ready for use. And their PD nurse in their clinic will take care of that. And then we will externalize the catheter to prepare them for it. In very rare occasions, we'll do an urgent start peritoneal dialysis. We don't recommend it in the hospital setting. This is something that they should be doing at home, where they have a little more control over their environment. And it's just because we're stretching the abdominal wall with the emergent start, it's still not going to give them any good clearances, but it's going to give them that little bit. But again, it's not a solution to urgent needs. And it's not scary. I think I hit on the fact you can't kill people with PD quickly. It's a long, slow death. So we're going to catch it early so it doesn't happen. And it's not scary. It really isn't. Trust me. Some of the folks that do PD don't even have electricity in their houses. And they're able to do it. It's not as comfortable for them. They're using the manual system where they hang a bag, put it in, drain it out. But they can't warm it up, so it's a little less pleasant. It results in some cramping. But if they can do it in a house with no electricity, we can do it in the hospital with all our high-tech gadgetry. Next slide, please. So let's talk about some of the most common problems that you guys see. Low drain volume. How many of you have had the low drain alarm? Is there anything more frustrating for you than a low drain alarm? Same. Inflow problems. Getting the fluid into the patient. You don't see that as often, but we're going to talk about it a little bit today. Have you had any patients with shoulder pain complaints? Back pain and hemoperitoneum when their drain bag is bloody. Next slide. Low drain volume is either a mechanical problem or a medical problem. If it's mechanical, follow all of the tubing from the drain line to make sure there's no kinks. Make sure, remember I was telling you about that little white clamp? Make sure that's open. And then ensure the transfer set is open. And we're going to play with that in a minute. Constipation. When you've got consistently low drain volumes, ask your patient when's the last time they had a bowel movement. We want to ensure that they're getting their stool softeners, because this PD catheter is sitting in the pelvis. And if they're full of stool, it's going to compress that catheter. So the fluid will go in and apply more pressure. But then once we've compressed that catheter, it's going to be a lot harder to get that fluid out. Adhesions or omental wrap. None of us can fix this. This is a surgical intervention. But the omentum from the peritoneal membrane has been known to wrap around these catheters to grow around it. And so then the fluid will push in, and that wrap will release enough for the fluid to go in. But then when the machine starts sucking it out, guess what else it sucks up? That omentum. And it's stuck to the tubing, and we can't get them drained. Finally, fibrin are the hair-like white strings that you've seen in these bags before. We all know fibrin is a part of the clotting system. And so, or if we see fibrin, they may have a high clotting factor, and we may need to notify the dialysis nurse so that she can talk to the doctor about adding heparin to the bag. Next slide, please. Inflow problems. Mechanical problems, ensure all the clamps are open on the foot. The big toe of the foot is the patient line. We want to make sure that that's open. We want to make sure any of these others that are connected to a bag are open. We want to ensure the transfer set is open. And again, I know you don't know what that is yet. We're going to get to that. That's going to be part of our hands-on game. Kink tubing, again, all of this is pretty easy stuff, right? Medical problems, again, fibrin. We want to roll the patient side to side to blow anything loose. We want to do the same thing with low drain volumes. Also, we want to raise the bed up when we're trying to pull fluid out. Raise your bed up so that it's higher than the machine. So gravity is on our side. If you do this, I cannot stress this hard enough. Because I don't know about all you, but when I went to nursing school, if you walked out of a room with a bed in high position, you weren't in nursing school anymore, right? And this is a special situation. So whenever I have to do that, I put up all 4 rails, turn on the bed alarm, and I tell somebody, be checking constantly to make sure they're safe. Fibrin, or the inflow problems, we want to lower the bed as low as it'll go. Sometimes it'll be low enough, sometimes it won't. But again, using gravity to help us out. The machine's got pressure, but gravity's around everywhere. So let's use it. So like I said, for the clotting, fibrin, anything like that, roll your patient side to side. Trying to fill them, lower them down. Trying to drain them, raise them up. Easy peasy? All right. Next slide, please. Shoulder pain. There's air bubbles in here. Just happens, just like we get the little tiny air bubbles. And sometimes they build up because they're doing this every day and may develop some shoulder pain just like they would after a laparoscopic procedure. Mild analgesics and their body will absorb it. Next page, please. Back pain. This is often related to a change in their center of gravity or changes in their body structure. So a lot of your peritoneal dialysis patients are going to look pregnant a lot of the time. So we are instilling anywhere from 500 milliliters to 2.5 liters of fluid into their abdominal cavity. Can you imagine carrying around a 2-liter bottle of soda in your gut and then trying to walk around with that extra fluid? It's going to pull your belly out. Ugh. You're going to look pregnant. Men, women, children, we don't differentiate. If it hurts, it hurts. So we work with them to try and increase their strength in these abdominal walls, but it's usually not successful. So we have to treat that with mild analgesics. Sometimes we have to lower the amount of fluid we put into them. Sometimes we lower the amount of time that's in there and just do more frequent fills, but a smaller amount or a shorter time. And again, repositioning and mild analgesics. Hemoperitoneal. Have you ever walked in and seen a bright red bag of blood? So this is post-surgical catheter placement, menstruation. We know that that's not where all of that goes, right? But sometimes a little bit of blood gets mixed up in the peritoneum. And all it takes is 2 milliliters of blood to cause a pink effluent, and 5 mils makes it look like they're bleeding to death. Peritonitis. So if we see bright red blood, and we know they haven't had a procedure today, and they aren't menstruating because they're 85 years old and a man, then we're going to want to notify the nephrologist, who's going to want the dialysis nurse to draw a sample. Ruptured cysts will also do the same thing. It looks scary, but it's not. 9 times out of 10. Now, if there's, well, not really. It's not as scary as it looks. I had a lady just a couple of weeks ago. Her bags looked like those red things on the wall. She'd had a PD catheter placed. And she was clotting around it, so we were heparinizing that. Then that sound like blood. But it's not near as scary as it looks. Next slide, please. So, PD patients. Bathroom privileges. This tubing is about 12 feet. And if you need to roll the cycler for them to get into the bathroom, it's got, I think, another 6 feet on that cord. Look at me, BRP. Or a bedside commode. But they can get up and back and forth to the commode. They can get up and move around the room while they're connected. Transferring a patient to a new location. Sometimes, I don't know if you guys do this at this hospital. Does your ED ever hold patients until they have to wait for a bed? Mm-hmm. You do? You guys do that here too? Okay, cool. Sometimes there are PD patients who need to get on treatment. And sometimes we don't know when they're getting a bed, right? So your dialysis nurse may go in and connect them in the ED so they can get on treatment. Because these are usually anywhere from 8 to 12-hour treatments. So if we get them on and they're still in the ED, they've got another 6 hours of wait. That's 6 hours of their treatment they're getting. So we're going to talk about how to take the patient and the machine where you need to go if that comes up. Or if your patient crumps and you need to move them to ICU. And then we're also going to talk about the emergency disconnect, and we're going to practice some of that today. Next slide, please. So I already hit on the bathroom privileges because I couldn't wait. Get it? I couldn't wait. That was kind of a joke. Transporting a patient requires 2 people. So if I'm connected to my cycler and I'm sitting in the ER and you come in and say, got your room, load up your stuff, you're going to either put me in a wheelchair or take me on the gurney. I got no dog in that fight. But you're going to leave me connected. And then your partner in crime is going to unplug this bad boy from the wall and push the cart while you push me to my room. Then when you get to the room, plug it in. When you plug it in, it's going to say power failure. And it's going to beep real loud. And you hit the stop button. And then you hit go. Stop and go. Now, this one is not going to do that. But as you can see, I didn't have to flip any switches or anything. I plugged it in and went right back to where it was. And that's what these do. Next slide. Emergency disconnect. You're hot, your room's on fire. You gotta get that patient out. You don't wanna have to wait and find some second person to push this machine, right? So you're gonna hit the stop button. We're going to turn the white screw section on the transfer set closed. We're going to keep this is the transfer set. This is what's connected to the patient's dialysis catheter from internal to connect to the machine. This dark blue section is a lure lock. This is the white twist cap. This is secondary coverage to prevent anything from leaking whenever they aren't in use, because this is connected to the patient. These are good for anywhere from 3 to 6 months if they're taken care of properly. So when you hear me talk about the white screw, open or closed. You want to pass that around? So if my patient's room is on fire, I'm going to hit the stop button. I'm going to twist that closed. And I'm going to disconnect the big toe. And I don't care what happens to the stuff here. My patient's room is on fire, right? Let it burn. We're insured, it's fine. But after I've disconnected them, we're going to apply, it's called a mini cap, and we always leave some on the cart. At least we're supposed to. And these are embedded with betadine, and they wrap around the dark blue component of that transfer set, and they keep it. So when you're connecting it to the transfer set, you want to make sure that that dark blue component is pointed downward, so we don't breathe into it, we don't get cooties crawling around in it. It's not going to be open for that long, but we just want to keep it downward to keep it clean. Making sense so far? All right. So, I'm going to run this through a cycle and we're going to play with it.
I do have a quick question.
Lay it on
So
me.
you're saying emergent situation and transferring a patient. There has been a situation, we cannot fit one of our beds from med-surg, taking a patient to IMU or ICU and that cart in the elevator at the same time, which yes, would be considered an emergent situation, but we also need to hook the patient back up when we get to IMU, and we've had this happen in the past. So we can disconnect. Are we able to take them down and hook them right back up?
That requires a second step, but yes.
Okay.
So I didn't bring that with me. Laura, can you run upstairs and ask Violetta to get me a flexi catheter in that cabinet? It's a flexi catheter. So if that's the case, and you've got to move them and you have to disconnect them. If their room's not on fire, and you're just moving them from one location to the other and you don't have room in the elevator, I can't stress this enough. You've got on a mask, they've got on a mask. Anybody in that room has got on a mask. Your hands are the cleanest they've been since you did a sterile field in nursing school. Because we don't want to complicate their upgrade and stay by adding any bacteria into their system. And then you're going to use that emergency disconnect process that I just told you about. But I'm also going to show you what to do with the machine so that you can take it with you. So that's a great question.
Are there sterile gloves in the cart?
Not usually. Not usually. Because everybody wears a different size, so we usually just take whatever size we wear with us when we connect them. And you can do it as a clean procedure. Sterile is just better. What else do you want to know? So I'm going to let this bad boy do its magic. Just take a second. So the doctors give us the prescriptions on how they want this run. You can't tell it once it's come to you, but there are different strengths to this diet meal that will have red bags, yellow bags, green bags. But you don't see that part because we remove it before it gets hooked up. And the red tags are 4.25% glucose content. These are all sugary. And we use the sugar to move the fluid. And so the more sugar they have, the more fluid we move. But also, you'll start seeing their blood glucose start to climb. So we try to avoid those, but you may start noticing their weight's going down. Look at that. Look at all the fluid they've gotten off of Mr. Jones. But his blood sugar is 800. That's stuff we need to know. So that way it may be time for us to make some adjustments in his prescription. The doctors, I'm sure the doctors are aware of it. Because you know, doctors are aware of everything, right? So it's just a good idea to make sure we share that information across both sides. And if our nurses aren't telling you how much fluid we removed, call the room and ask them so that we can get it into their I's and O's. Because they should be calling to report that or stopping by the desk. But sometimes they don't find you. You may be in a patient room somewhere and they've got to go get a hemo patient put on. So if you go into your PD patient's room and they're not on anymore, give the nurse a call so they can let you know how much they took off. Fair enough?
It's supposed to be documented somewhere?
I think they document it in the I's and O's, but I'd rather have over communication than under. And that way, if they did have any problems, they can share it with you guys or you can share it with them. Like, hey, night shift said his blood pressure got kind of low last night. Well, yeah, we pulled a bunch of fluid off of him this week. We need to adjust his prescription. We will adjust their prescription if they're admitted with hypotension. Their prescription from home may not match what they get in the hospital. This is one of their biggest complaints from the PD patient side, is they do it all at home according to their schedule. Kind of like their medicines for hemo patients. Well, I take that at this time and I take that at this time. Same concept here. We're adjusting their routine to the hospital's routine. They have every right to be frustrated with that, especially when it's something they feel they can just be doing themselves. But if the doctor has changed their prescription, their machines are pre-programmed. They have a computer chip that's inserted into it. They don't have to do the manual programming of the machine like our nurses do. So they're not going to know how to change that because they won't have the computer chip. So, any other questions? So I usually have my apron that I connect this to when I make everybody put me on PD treatment. I won't put you through all of that today. But I am going to have my transfer set hanging out so y'all can play with it. All right? Also, they don't prime fast. They don't get in a hurry to prime. So one of the things that I wanted to share while this is finishing up is when we are starting these, we don't know when they come into the hospital where they were in their cycle at home, right? They may have done a complete treatment. They may have been partway through a treatment. They may have fluid sitting in their belly because they just got sick and had to come to the hospital. They may be dry as a bone, but we don't know. And we're not going to send everybody for an ultrasound for their first treatment, right? These machines automatically go into initial drain mode. So they're going to, we program what we expect for us to pull out. So if they tell us, yeah, I've still got a liter in there, we can adjust the programming so that it knows to pull off a minimum of 750. Or if they say, I've not done treatment in 3 days, we can set it to pull 10 mils. Because the odds are good there's nothing in there. Because our bodies will have absorbed it. But that initial drain alarm is usually that we've set it for like 700 because they tell us there's fluid in there, but they don't know that their wife came in and drained it while they were sleeping. And so then it's alarming because we think there's fluid in there. The machine thinks there's fluid in there, but there's no fluid there. So that's why your dialysis nurses should be staying through the initial drain so that we can troubleshoot that first section. Because it's a pain in the butt whenever it doesn't work. When the machine thinks there's stuff there that's not there. And we have to wait for it to alarm because you can't do anything to it until it's alarming. Dear, I'm sorry. I'm glad I grabbed that bowl. I'd be wearing sticky peritoneal dialysis. And it's sticky. If you've ever had it on the floor, it's almost like walking in a movie theater from the 80s. Sticking your feet to the floor. The dollar theater. With a little pee mixed in for, you know. Because that's what that is basically, is just pea water with a lot of sugar. Don't you love all my technical terminology?
The Baxter hotline is very helpful.
They are exceptionally helpful. This is all they do all day. The hardest part is getting them to realize you're not a patient in a home and that you're a nurse in a hospital. But that phone number, if you tried everything I've shown you and you still can't get it to work, that's your team right there. And then there should be little booklets on every cart with some troubleshooting techniques. All right, so. Of course, I'm doing all this nice and clean and sterile, right? All right, so I'm connected. And I'm going to hit go. So, initial drain. I've got a dry belly. It's set for 0. But it's still going to try to pull something just in case. So it's in initial drain. So it's trying to pull fluid out of me. I'm dry as a bone, but just to be safe, it's a fail-safe on the machine so that we don't overfill anyway.
So if it finds fluid, does it let you know?
It'll just count it on the screen that it had an initial drain of, say, 20 mils.
Okay.
Now, these toes that aren't connected to the bags should be closed. Their clamps should be closed. Because they're not connected to anything, they shouldn't be primed. So if they're not connected to a bag and you're troubleshooting, you can skip those parts.
What are they for?
For extra bags. So if we've got 2 or 3 bags that we have to run off of, we can program the machine to run different strengths at the end. Like I was talking about earlier, somebody keeps a wet belly. For some patients, it's more comfortable to have fluid in there, so they may keep like 500 mils in there through the day, so it's not dry and rubbing up against itself. Because you're a lot more noticeable of your peritoneal membrane when you're using it as your own personal artificial kidney. So sometimes they keep fluid in it so that it's just as a lubricant, so it's less tender. And sometimes we'll do that with a higher strength Dianeal, so that as they're walking around through the day, it's pulling fluid. So then we may put 500 in them at last fill. And then as they walk through the day, we know we've got a 500 initial drain, right? Oh, look, I've got an alarm. Who wants to come work on it? So this is a drain problem. What do we want to check for first? Correct. So our drain line's open. So that's good. Right? What else do we want to check? Check your transfer cell. Is that closed?
Yeah, so it needs to be
It needs to be open. Yeah. Good job.
Yeah.
That's all there is to it. So, most important button on this machine is stop. Because that's the mute button.
So if that happens and we get it and it's closed or there's a kink, will it just automatically,
You'll just hit go again.
you just hit, okay.
Yeah. Stop shuts up the machine, go starts it back up again. 'Cause to me, the first thing I ask on any piece of equipment I'm learning about is how do I make it shut up? Because I can't think with stuff beeping in my head. I don't care if it's a vent, I don't care if it's a CRRT machine, I don't care if it's a feeding tube. I've lost my feeding tube privileges for forgetting to turn the kangaroo pump back on. But I need to know how to shut it out so I can think. All right, so we're still in initial drain. So it's pulling, amazingly, it's pulled 8 milliliters out, but it's just fluid that's in the tubing. I promise I don't have 8 milliliters of peritoneal dialysis fluid in here.
So how many of the top bags can fit in those bags? Like,
This-
if that bag ever gets too
This
full?
bag is a 15-liter bag.
Okay.
So this is a 6-liter bag. So we may have them on 12 liters of fluid and still give them a 15-liter bag. Anything usually over 12 liters, we'll split it so that it's in 2 bags, just so it's easier for us to handle whenever we're having to eliminate the effluent, and so the bags don't pop. Because someone made that mistake one time. And did I mention sticky, yucky pea water everywhere? Yeah, one line.
How do you get it on 2 bags?
There's a Y connector that we can attach to the drain line. And then we can work it out when you put a drain bag here and a drain bag there. All right. Come on, I'm trying to bypass the initial drain.
So we recently had a patient who does PB at home and said that, typically the onset, she has issues with the initial drain and her home machine is able to bypass it. And what I learned from Baxter was that we cannot do that on these machines.
We can,
Okay.
but there's a special set of circumstances. My general rule of thumb is that if it initial drain alarms 3 times, and we know for a fact that there's nothing else in there, then it has to actually be alarming for us to bypass it. So if I go in and it's an initial drain, I can't bypass that right now. It has to be actively alarming for me to be able to bypass that. My request is that if you feel like you need to bypass it, A, call the nephrologist to make sure it's okay with him. B, call Baxter so that they're walking you through it. But you said they said we can't do it, right? Okay, my mistake. Because you're not trained dialysis nurses, this is for your safety that you're verifying it with the nephrologist. If it's before 9 p.m., call the dialysis nurse. Fair enough? Because that's why the dialysis nurses are really supposed to be sticking around through the initial drain to make sure if there are any problems, they're here to address it. And share that with your team on their homework call. But that's a great call out. Great call out. Come on, bad boy, let's go. This is why we don't pay a nurse to stand with patients while they do PD. It takes forever.
I hope they don't abandon you,
We do pay them to stay with hemo. That exsanguination thing is not pretty. We're not paying for that. So I hope that this has been helpful. Okay, so we're going to pretend that this is cooperating and that I'm actually mid-cycle and we're getting a low drain alarm. What are we going to do? Do you remember? Check for kinks.
Change position of bed.
Roll side to side. Right. And have they had a bowel movement? That's not a quick fix, but it's an important piece of information to have. Because especially if they've had hip surgery and they're on NARCs, we already know what those complications are going to be like without throwing peritoneal dialysis into the mix. Or we can't get anything to go into them. What are we going to do? Lower the bed?
Check the clamps.
Check the transfer set. Okay. All right, so now we're going to practice the emergency disconnect process. And you're going to move the machine with me, all right, while I'm disconnected. Since you had the question, you get to come demonstrate. So everybody in the room is masked, right? Our hands are cleaner than they've been. So you're going to hit the stop button.
So we're moving, this is a situation where this can be moved
Yes.
with you.
This isn't on fire. This is, we're moving me to INCU. We're going to hit the stop button. Then you're going to close that white clamp. Yeah. And then you're going to twist that closed. Okay, so right now, my drain line is still fine. This is the big toe. So this is where the patient's fluid is coming from. We want to clamp that. And you're going to use what we call a flexi cap. Which Laura just brought me. Where did I put it? There it is. They're bigger. Mini cap, flexi cap. The flexi cap also has betadine embedded in it. And it goes on the end of the big toe to keep that clean. And then your mini cap so now your patient's disconnected. You can move your patient, unplug it from the wall, take it up to where your patient is. Then you're going to hook me back up. So you're going to keep it pointed downwards. And then chuck that. And untwist. And then you'll hit go. Not near as scary as it sounds, is it? I've told you what's scary. And then we're back on treatment. Questions, comments, or concerns? Feeling good about it? Anybody want to jump rope? And it disconnected from their catheter? Because that happens. You're going to throw all this aside. You're going to notify the physician. But that catheter now, pieces of it are flopping out in the wind. You're going to put a hemostat on it. You're going to wrap it in alcohol soap gauze or betadine soap gauze, and you're going to call up the nephrologist. The odds of that happening are slim, but it does happen.
And they keep the clamps with everything too, correct?
I beg your pardon?
And the clamps are with everything as well?
Yeah. So, anybody want to come look at the machine, play with the machine, or y'all just ready to go home and go to bed? I can get that. I was a night shifter. Loved my night shift crew. So, all right, that's all I have today. Anyone else need any information, questions? We have this slide projection. We're going to be sending it to Andrea and Tammy and everybody so that you can have it just as a refresher if you need it. So thank you all for taking the time to come. I really do appreciate it.
Thank you.
And thank you for being so interactive.
I sent it